Radiology case for the day. My name is Nick Kuntz, and I'm a neuroradiologist and head and neck imager at Indiana University School of Medicine. And I'm back today with another interesting head and neck case of the day. Let me start by stating that all of the educational content found within this presentation has been completely de-identified in order to protect patient privacy. Okay, so for this day's case of the day, the clinical history is lump after a cold. Patient started feeling a lump in their neck after they've had a cold. Okay, so I've got three images to look at. The image on the left is an axial contrast enhanced CT. The image in the middle is a sagittal contrast enhanced CT, and the image on the right is a coronal contrast enhanced CT, all through the level of the abnormality. So take just a look at the images, take a moment, try to figure out what's going on here. Remember, the history was a patient who developed a lump after a cold. And in fact, I'll tell you, if you pressed him further, you would find out that this is not the first time it's happened. Okay, so two questions this time. First, what are the findings? And then the second question is, what's the diagnosis here? All right, let's start by looking at the imaging. The first image to look at is an axial contrast enhanced CT. And what you'll notice is there's a small rim enhancing mass. This yellow arrow is pointing right at it. And this is centrally of low density, although there's certainly enhancement surrounding it. And if you look at the location, it's right adjacent to the strap muscles. You can see them sitting just behind it or just deep to it. And this thing is more or less at the level of the hyoid, but if you looked at the sagittal and coronal images, and I'll show you those again in just a moment, you can see that this thing was minimally extending above the level of the hyoid and minimally above the level of the hyoid. So let's look at our sagittal contrast enhanced CT image, and again the yellow arrow is pointing right at our finding, and you can see that rim enhancing low density mass that's sitting at the level of the hyoid and extending just above it. And this is an image that was obtained just more or less right at midline. So above the level of the hyoid, this lesion is found at the midline. And then as we look at our coronal image, we can see that as you go below the level of the hyoid, the lesion extends below it, and it fans out just a little bit to the left. So something that's at midline above the hyoid and extends just off midline below the level of the hyoid. So what's the diagnosis here? Well, this is a thyroglossal duct cyst, and in this case, it's an infected thyroglossal duct cyst. Thyroglossal duct cysts are benign cystic remnants of the thyroglossal duct, and it's important for you to know what the normal course of this developmental thyroglossal duct is. And it extends from the foramen cecum, which is found at the midline base of tongue, all the way down to the thyroid bed. So whenever this embryologic feature fails to involute or involutes incompletely, we're left with a thyroglossal duct cyst, and that's what this patient had. And those can occur anywhere along the course of the thyroglossal duct. So in the suprahyoid neck, these are found in the midline, and below the level of the hyoid, they're found paramidline. They'll sort of fan out either to the left or to the right of midline as you go further south below the hyoid bone. And interestingly, there's a bell-shaped distribution to where we find these. About a fourth of the time, we'll find them at the level of the above the hyoid. Half the time, we find them at the level of the hyoid, and then the other fourth of the time, we'll find them below the hyoid. Again, when they're above the hyoid, they're midline. When they're below the hyoid, they tend to be off midline. These are the most common congenital neck mass. You absolutely will see these if you do neuroradiology, pediatric radiology, general radiology, ultrasound. You'll see these. These are quite common. And they can recurrently get infected, most commonly following or associated with a recent upper respiratory tract infection. And so if we probe this patient's clinical history a little bit further, you'll find that this is something that he's dealt with many times in the past, where something sort of flares up, gets a little bit bigger, gets tender, a bit swollen there, and then goes away. So here's a nice paper by Patel and Bhatt that was published pretty recently in Insights into Imaging, and this is looking at the thyroglossal duct, some of the pathologies that are associated with it, and some things that can mimic thyroglossal duct abnormalities as well. So it's worth taking a peek at, especially if you're a resident or a neuroradiology fellow. It's a nice review paper. Okay, so let's wrap this up. Again, this was a case of a patient who had an infected thyroglossal duct cyst. And the key imaging features to know are that this is going to be a cystic mass. In the suprahyoid neck, these are found in the midline. They can extend all the way from the foramen cecum at the base of tongue in the midline down to the level of the hyoid bone. Below the hyoid, they fan out either left or right into a paramidline location. Don't be fooled by wall enhancement. You'll see that, especially in the setting of current or prior or recent infection. And oftentimes, if it's infrahyoid in location, these can be embedded within the strap muscle, or at least partially embedded. And it gives you a claw sign in which the thyroglossal duct cyst is partially encased by that strap musculature. There are some pitfalls to be aware of. The first is that if you see calcification in a thyroglossal duct cyst, you need to be very, very concerned, because that's highly associated with malignancy. It's a very specific finding. When you see it, those patients, you should absolutely be concerned that they've developed thyroglossal duct cyst carcinoma, which is typically going to be a papillary carcinoma. But when you see a soft tissue component or when you see enhancement, that's oftentimes nonspecific. In fact, that's always nonspecific for the most part, unless you see aggressive features where you see soft tissue that's extending out beyond the margins, invading the surrounding structures, or associated adenopathy. But just because it has some soft tissue component doesn't necessarily make it cancer. You can see it with cancer. You absolutely can see soft tissue components. You will see soft tissue components with malignancy. But commonly, we also see that in the setting of prior infection or inflammation. So just keep in mind, calcification within a thyroglossal duct cyst, always suspicious for malignancy. Whenever you see soft tissue, a soft tissue component to it, it can be associated with malignancy, but it's nonspecific, and more commonly we see that in the setting of prior infection or inflammation. These are certainly prone to becoming infected. It's a very classic presentation that these will enlarge or have recurrent enlargement, waxing and waning of these whenever patients have upper respiratory tract infections. So be aware of this entity. You will see it if you're a practicing neuroradiologist, pediatric radiologist, head and neck imager, or even a general radiologist, someone who's doing a lot of ultrasound. This is a common diagnosis, and I think it's something that we all need to know about. Well, as always, thanks for tuning in to IU Radiology Case of the Day. You can follow along on Twitter at @NAKuntz, and I would invite you to check out our complete collection of IU Radiology Case of the Day materials that can be found at radtf.iuhealth.org/COTD. Thank you.